welcome you to this webinar, Adaptation and Response of Health Institutions in Mexico in the Pandemic by COVID-19, Capabilities Tested in Changing and Complex Scenario. We welcome you. We thank you all the panelists, all the that are specialists in the topic, and all the participants as well that are accompanying us. I am going to present the coordinator of this webinar, Maestro Carlos Iván García Díaz, who is a specialist of the American Commission of Organization and Administrative System, CAOSA. He is public administration with master in management administration by CIDE. He has been a junior analyst in the interdisciplinary program of CIDE as well, and he has worked in several dependencies on administration public of Oaxaca government. He has been a director assistant in the Inter-American Center of Social Security Studies, CIES. In this moment, I will give the floor to the coordinator, and I wish you all success in this activity. Thank you very much, Dr. Gwendolyn Bravo, academic coordinator from the Inter-American Center of Social Security Studies. We summon all the public institution of health public to talk of the response of all the organizational and management perspective to the pandemic by COVID-19. We pretend to be a space of encounter for high functionaries of government healthcare institutions destined to research as well as educative institutions that have been make important studies. This webinar is one of the 4 strategic axes stated on the American Commission of Administrative System, CAOSA, from by the 2022 period, about the analysis experience on managerial financing and human capital at health attention and service attention that are given in all the different social security systems in Mexico. Without any more introduction, and saying that all our guests will help us to understand all this context. SARS-CoV-2 virus causing by the COVID-19 pandemic tested the institutional capacities on the health public institutions to adapt and give response to this very difficult context. In Mexican government was not exception, and who the diverse institutions that comprise the health sector, they implemented strategies to prevent the spread of the virus, expand hospital infrastructure, equip and train medical personnel that were at the front line. They were also worked in simplifying administrative procedures and services to provide faster medical care for the infected and a potentially more vulnerable population, as well as to implement mitigation measures to address the profound economic and social consequences to confinement and mobility restriction. These changes implied transformation within the administrative structure that impacted the organizational structures. They redefined as well function and adjusted the applicable regulations. It was also necessary to generate cooperation mechanisms abroad, interactions with international organizations and the rest of the countries to share information about the registration and behavior of the virus, as well as prevention protocols and emerging treatments for patient care. The above in order to These are some of the issues that will guide the exchange of ideas and experience accumulated in Mexico. The above in order to stress the importance of having institutions with the organizational and administrative capacities. um, how does the organizational schemes and processes in which healthcare institutions operated prior to the pandemic were modified? How were inter-American and intra-institutional efforts coordinated to address the health emergency? What lessons were learned, and how can we improve the government's capacity to prevent, act in due course, and adapt to complex and changing scenarios? The above in order to stress the importance of having institutions with organizational and administrative capacity to respond to changes in their environment. It is also important to rely on scientific evidence and international cooperation to assume strategic perspective in planning and management of public health and social protection policies. This is a necessary condition. This is a necessary condition in our times, so we can face the only certainty we have that everything changes and nothing remains as Heraclitus stated. First of all, we are pleased to have here Dr. Oliver Mesa. Um, who is a professor in the Public Administrative Division of the Center of Economic Research and Teaching CIDE in the central region of Aguascalientes. His undergraduate training began with a degree in international relations at the Instituto Tecnológico of Estudios Superiores of Occidente. He later graduated as a teacher in public administration from the London School of Economics and Political Science in the United Kingdom. In 2011, he was a visiting scholar at the Lyndon B. Johnson School of Public Affairs at the University of Texas, Austin. He received his PhD in public policies in Mexico at CIDE in 2013. Dr. Mesa has publications including articles in prestigious national and international magazines, 8 book chapters, and 2 books. In 2020, Dr. Mesa received the 2020 Research Award in the area of social sciences from the Mexican Academy the Mexican Academy. Among his most recent publications are 3 that touch on the subject of medical hospital services personnel, managerial challenges of emotional labor disruption, the COVID-19 crisis in Mexico, the hospital management of the pandemic in Mexico City, and analysis from the approach of bureaucracy at street level. Please, doctor, we give you the floor. Thank you very much. Good day. I would like to thank the older organizer, Dr. Daisy Corrales. I am honored to be invited for you and Maestro Carles as well to share this in this panel, in this moment, some of the findings that we have after this phenomenon. We also thank you. I also thank all the panelists. It's an honor to share my time with you. I'm going to refer briefly this speech that we have titled Lessons from the Pandemic in Public Health Institutions. I would like to talk you of the context who led us to research the phenomenon of the hospital, specifically a phenomenon that us in public administration known as level street bureaucracy. This bureaucracy is basically all the officials that have direct contact with citizens, or in this case, with patients. We are talking of a team that was organized quickly just after we known of the pandemic. This team was formed by Dr. Elizabeth Perez Chiques, Dr. Sergio Campos, Dr. Samantha Varela, and myself. We focus to know how the work was modified of this bureaucracy at the street level, especially hospitalary staff, and how their work was modifying their interrelationship being modified, as well as their relationship with the patients in a unique context that we faced once in a lifetime, very disruptive as well, and very with a high level of uncertainty. Within this context, we have into consideration that there was an interested phenomenon for the researcher, where we had a very big limitations, because we were confined in our homes, in our zones, precisely to avoid the contagious and the spread of the virus. And that we had to deal with difficulties that before we haven't dealt with us. But nevertheless, we believe that exploit these kind of scenarios can also allow us to find creative alternatives in order to develop first-hand research. I would like to refer myself 4 lessons that we could learn, and it will be very interesting for public institutions in disruptive events and with high degrees of uncertainty. We believe that this could help to the daily day. I'm going to explain each by separate. The organizations need to foster collaborative and interdisciplinary work schemes to generate meaning within the uncertainty. We are going to look at what were the results of our research. The second one, the discretion within the work of hospital staff cannot be eliminated, only can be oriented. Number 3, staff should be supported to expand the range of their functions or modify their traditional role from within the organization. In the context of a pandemic, we saw that activities and roles that normally the hospitalary staff had to be modified abruptly, because of the nature of the virus, and as well because of the new guidelines of sanitary authorities in order to face this pandemic. The fourth is management must find alternatives so that the emotional work, I'm going to explain that normally performed by hospital staff is not interrupted to the detriment of dealing with patients. So this speech has as a base some of these researches that I believe it would be interesting to disseminate among the community. There is an article of Guanajuato University, the hospital management of the pandemic in Mexico. We have also 2 other articles of international analysis. One that is about the different roles of street-level bureaucrats in Mexico. It was published by the Journal of Comparative Policies Analysis. Another one that was also published in English by the Review of Public Personnel Administration, which is the emotional labor of hospitalary staff. And the fourth article, the fourth job is a book, A Better State, Lessons of the Pandemic to Administrate the Public. And it speaks specifically of the transformation of the work of the hospital staff. I'm going to refer to the first one that is related to the organization and the need to foster or propitiate collaboratory and interdisciplinary work schemes to generate meaning within the context of uncertainty. The first challenge is what are we facing? What can we do? Or the responses that normally we know the responses of these questions. We are not prepared to offer the we don't have a lot of backgrounds, or we still haven't been able to identify which are the relevant backgrounds from within the big clinic and scientific backgrounds of the clinic information. And what we observe of the hospitalary staff is a modification. Someone were telling us in the interviews, we have never worked in this way. We generally work by specialities, by teamworks, where we share the language, we share premises, we share the information and experience. But facing a phenomenon like this, we had to dialogue. There was a very interesting phenomenon that we identified, at least in 5 things. A much more multidisciplinary work in which where there was no a single treatment, they were all working hypotheses that came from the several specialties that were comparing results, and therefore the work became more multidisciplinary. They had to go out from their own specific discipline in order to understand what was going on in other specialties. Therefore, to share this information, there was a very important communication work. Because there was no specific response, the response was building in the process. With the voices of different hierarchies, different specialities. It was a very complex process. It wasn't easy. Some of the staff was saying that it was, even though it was difficult, it was necessary in order to give sense or meaning to what we couldn't still have in mind. Multidisciplinary work produces as well a much more horizontal work, because the hierarchies are erased, are blurred, because there is no complete knowledge on the subject. Because all we have to learn from everyone, we have to discuss of the phenomenon, and we all have to try the best way of dealing with the patients and dealing with the disease, because we didn't have at that time knowledge of what was going on with the disease. This was a learning process that has experience as a basis, and the capacity that we saw in some hospital very high, but indeed there was a same mistake process. It was quickly evaluated, this procedure, or whether it was better or worse than another, or whether this procedure could replace another one. And based on a teamwork to take a decision or to make some recommendation to ameliorate the treatment to the patient. We saw in the people some self-motivation with a clear ethical sense of their work facing the society. People who at the beginning showed some fears for it was normal, but self-motivation was necessary in order to keep this work process of multidisciplinary, horizontally and deliberation work in order. especially at the beginning of the pandemic. Another lesson that we could take is that the discretion within the work of hospital staff cannot be eliminated. It can only be oriented. I said this because sometimes there was the idea that some bioethical guides had to orient the work of the staff, but we saw that the guide really was working very well, but with the limitations that they couldn't eliminate the discretion of the patient. This is very important because this is the guide of the aim of the guide. Even though in the majority of the states at the beginning of the pandemic, a lot of states didn't know the guide. So they work with the available resources. I live here. Some states, I haven't heard of anyone using these guidelines. The hospital doesn't accept people when there are two ventilations left. If they don't come these two beds to the hospital, we don't even check it. We just make sure they are stable. Stability also changes definitions because someone who arrives with 80 saturation can now go find another hospital. Saying sending them home was very risky for the patient. For example, Mexico City, at least there were more hospitals. In other places where there existed one hospital or two COVID hospitals, this decision of letting people go to their homes had much more difficult implication. At the end, the staff had to adequate the guidelines depending on the local context. Even on the same guide, they promoted they promoted there is the allocation of limited resources of critical medicine in emergency situations, and they call us to reconsider to implement intermediary organism from within the hospitals that could serve to concrete the policies in the local hospitals. And what we observe directly that the street level bureaucrat being discreet to attend the people. Number three, the staff should be supported to expand the range of their functions or modifying the traditional role within the organization. This is very important, and this is registered in one of the articles that we wrote. We identified in the interviews that the main part of the staff was focused to attend the patient. But when a COVID-19 phenomenon arrives, we have another logic to consider that is related with the public resources to decrease mortality. There is another role that is not necessarily absent in other moments, but in a moment like this, it emerged, and it's the resource rationer. So we have some activities between this resource rationer and patient attention, in which the decisions could be has to be taken, trying to balance these two roles. And sometimes one decision seemed to contradict the other. We found a lot of four sub roles, activities related to ration the resources. Other were patient oriented. Another was the self protection or care of the people and the team work to keep working. And the other sub-role was the balance under stress. I'm going to make some examples. There were some activities that were modifying a lot. For example, the patient-family bond, that the family member will not remain in doubt because they are afraid. They don't know what's going to happen, but they don't have all the time to sit down and talk with all the patients and families. There are a lot of eagerness to find something that can help serious patients. Part of this problem has much to do with the anguish of one that if someone arrives very sick, what are they going to do? What are they going to give me? There was another problem that is all the personnel that were working at the hospital. They knew that when they arrived to their homes, their family were at risk. Some other variety in cerebral activities were the patient evaluator. How to respond to the resources that might have to be used to care for this patient. Should we treat them? Another deliberation role. A bioethical guide was published, but to be honest, the work was so intense that we never had a session to discuss it. Nevertheless, all the decisions that we took were made by consensus. A phenomenon such as this modify the activities very importantly. I'm going to talk of the last one. Management must find alternatives so that the emotional work normally performed by hospital staff is not interrupted to the detriment of dealing with patients. Emotional work that the people do to keep neutral or positive during the work, especially facing the patients, is it's a work that we have to do to avoid exploding due to stress and uncertainty, as well as when we don't have conditions to attend the patients. It's very important that hospital managers knew all this emotional work, and despite a lot of restrictions, they had to organize a lot of activities so the work staff, so the hospital staff could deal with all these patients and all these problems. They have to keep morale high among staff. The emotional work performed by hospital staff is crucial to the goals of any hospital. The manager of the hospitals they had to offer the doctors recognitions to staff, sometimes in economic or moral manners, maintain as well constant leaderships, promote a context of tolerance to frustration, and promote a safe space to talk about all the problems. They have to promote as well self-care and mental health in the staff. So I finished with these 4 lessons. It was very brief part of this of the work, but I invite you to read all the articles. Thank you very much for your attention, and thank you very much for your time. Thank you very much for your participation, Dr. Mesa. It's very interesting to highlight these 4 premises in the sense that pandemic meant an abrupt change with a lot of uncertainty, and when these all events that are unpredictable on the contagious grade emerge, the organizations support themselves in what is happening, in what the hospital staff were doing. For example, in all these guidelines, they had to adapt all these guidelines to the new circumstances. That implies a break to this traditional hierarchical structure. And this work, this interdisciplinary and multidisciplinary work, among all the medical specialties, to restate these such so necessary protocols to generate new protocols in order to help patients. This another idea is that, as you were stating, they have in the real work is far from from a guideline, so it was very important to transform it. And sometimes a hierarchical structure are problematic. So therefore, this formal structure is only with 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 changes from within the organizations. This includes as well this freedom spaces of decision that the professional had to have in order to deal with this pandemic. We will have at the end a question and answer session. If the public want to ask you something, Dr. Mesa. So now we have to give the floor to an eminent doctor who for 10 years headed one of the leading national health institutes that treat the first cases of COVID-19. Dr. David Kerstenovich of the National Institute of Medical Sciences and Nutrition, Salvador Subirán. He is a medical surgeon from the UNAM. He did his residency in internal medicine and gastroenterology at the National Institute of Medical Sciences and Nutrition, Salvador Subirán, and the specialty in hepatology at the Royal Free Hospital in London under the mentorship of Professor James Sheila Sherlock. He obtained a doctorate, a PhD in medicine at the University of London, and he participated in the creation of the first liver clinic in the country. A hospital where most of the hepatologists have been formed in Mexico. His research focused on the pathophysiology of liver cirrhosis, mainly in the field of fibrosis. He has been pioneered in clinical research in C. hepatitis in Mexico. He had published more than 230 original articles, 7 books. He has 9,000 citation, more than 9,000 citations to his works. He is researcher emeritus level 3 of the National System of Researchers of CONACYT. He was member of the UNAM Governing Board from 2010 to 2012. He was president of the National Academy of Medicine in Mexico. He was secretary of General Health Council. He has received several awards, including Miguel Otero Arce Research Award at the Eduardo Lisiaga Award from the General Health Council of Mexican government, the Doctorate Honoris Causa of the National Autonomous University of Mexico, and the National Prize of Sciences 2016 in the field of physical, mathematical, and natural sciences. He was member of the Advisory Council of the National Human Rights Commissions from 2016 to 2021 at the National Institute of Medical Sciences at Salvador Subirán. He was head of clinical service, teaching coordinator, member of the Ethic and Research Committee, head of the Department of Gastroenterology. From 2012 to 2020 to June 2022, he was the general director of this outstanding institution. I would like to see Dr. Kerstenovich that comes very ad hoc between his personality and the context of this webinar. Dr. Kerstenovich is perhaps the only scientist who finds peace in chaos and peace in the zero predictability of chance. We give the floor to the Dr. David Kerstenovich. Lessons and learnings of the attention to COVID-19. Thank you very much. I'm going to share my screen. Thank you very much for the invitation. And as the title is saying, there are a lot of questionings regarding. Am I being listened well? Okay. There are a lot of questions relating this pandemic, this COVID-19 pandemic, and I would like to put some affirmations before I start my speech. The SARS-CoV-2 pandemic is an unprecedented test of efforts for national health services, and it has tested the planned crisis of the several hospitals at the country. The balance between knowledge and the quality of medical care is placing increasing demands on health systems and doctors. It has been a very important challenge. We have an unknown virus, and by the other hand, the country was affected by a great deal of comorbidities, obesity, diabetes, hypertension, and all of that was a very explosive mixture of risk factor. And that is when we ask ourselves whether 2 plus 2 is necessarily 4. But there were external factors such as news uncertainty, fear, the challenge amid reactivation that we are still living nowadays with the possibility of a new wave that's fortunately it has not the same mortality range. There has been development that I will refer lately, such as virtual reality, teleworking. A very important external factor is that different from other pandemics that were very slow to disseminate nowadays due to the technological and communication advances, the dissemination of infection agents is much more quickly than what happens centuries ago. That is also accompanied by a very important thing, that is the concept of one single health. That is because it's related that the virus does not affect only the human, but they also affect animals, and they are lately transferred to humans. Environmental factors are also in the game. So with these backgrounds, I'm going to reflect a little bit on the lessons of COVID, since from an institution that is focused on that patients, on COVID-19 patients. So these are the topics that I'm going to deal with. I'm going to talk about sunstone, time, comorbidities, vaccination, immunology, variants, what does hypoxia and ischemia means, post-COVID syndrome, new antivirals, the opportunity developments, collateral damage, and mental health. Octavio Paz stated that time perception was always relative, and it's related with the state of the mind. He was talking of the factors that we must have in mind, that which is memory, discernment, humanism, ethics, science, and nature. All of this is mixed with this first representation of what has been COVID-19. Really, in space-time and centuries, we have only had 2, and we have been in the third year of the development of this pandemic. When we saw during time, it's a very, very small amount of time. We can see, for example, how research and science here in yellow has been developed very quickly in this period of time. COVID-19 has presented in several waves in such a way that we have a new wave. This have seen this affected, for example, schools that were closed a long of time and that from December 2021 started to reopen. The economical fluctuation and how economy was affected. So there's a lot of factors, but in time scale, it's a very, very small amount of time. One of the first facts that we learned is that about three-quarters of Mexicans who have died from COVID-19, 72% had at least one chronic disease, such as hypertension, diabetes, or obesity. And we have learned that these comorbidities are a very, very important risk factor. We also have a vaccination. Mexico, a difference of other countries, have experimented at least 8 vaccines that you can see here, 7 vaccines that you can see here, differently of other countries that had only 2 or 4 vaccines. Vaccination affect not only to public health but also economical systems of a country, to socio-cultural patterns and to political institutions. We have all seen that all these factors have been affected by the vaccines. Governments and the WHO should build on the experience of COVID-19 vaccination to advance, to go forward to positive impacts of vaccination. Why? Because prevention still being the best way of facing these diseases. And in a very short amount of time, the vaccines were developed. There's been vaccines have been one of the most significant advances in science and medicine for over 200 years. They have contributed to eradication or control of many diseases. The other important concept is the immunosuppression. These infections produce immunosuppression. Also, the fact that the population is aging and the immunosenescence and inflammation associated with age are also risk factors. We have here some research studies made at the institute that talk of the over life of created lymphocytes. I believe that there is going to be a very important change on paradigms in immunological systems. For example, why some vaccines, such as smallpox, is longs a lot, and other vaccines, such as SARS-CoV-2, have a very short amount of effectivity. The next factor is related with the development of variants. This is a normal way of evolving, that virus having of adapting in that fight that is established between some nucleic acids of the virus that appropriated immunological system and that suffering changes. So we have seen all the variants in the country and in the world. These variants occurs fundamentally in the spiga protein that we saw here represented in yellow, in the genome structure of COVID-19, and how these variants have been developing. Look, the important name of a mutation number that have been identified, and it's a very important number. The number of mutations that have been established on time between nucleic particles that constitute the virus and the immune system are what are making the presence of the variants. That led us to 3 aspects that we have learned to have into consideration. what is the transferability of virus? What is the possibility of vaccinations that the percentage of vaccination influence in the transferability? The vaccination is related to ability to prevent infections with natural T killer cells, and it's very important because vaccination what makes is to prevent hospitalization and to prevent the severity, not necessarily, as we have seen, eliminate completely virus. Therefore, when we talk of virulence, we talk of mortality. We have a lot more mortality, and that is also related with vaccination. The challenge is how to find the vaccines that list along related to protection, and the T natural killer cells and are becoming uh, research focus, very important research focus. So what we have learned of COVID-19, we have learned that it's not only the virus, are also the comorbidities, the immunoessence and inflammation, the immunosuppression and the autoimmune disease and vaccination, among other factors. As I'm going to show, we are learning by research very important um, issues such as hypoxia and ischemia. We know that animals submerged by sea can breathe, but also by in the terrestrial. How are they adapted? We know that all the tissues that behave in the body they behave differently. For example, there are tissues that cannot be regenerated, such as the neurons. The challenge is how to make these tissues to regenerate. Others have a medium possibility, such as intestines and lungs, and some others that can regenerate, such as endocrine cells. We can see here such as in the presence of hypoxia and ischemia, how can the damage on the tissues can be in seconds, minutes, and hours. So the mitochondrial structure is lost, and but how hypoxia, how the sick that is affected. These are research questions that will be very relevant as the time goes by. This make us in the future years the post-COVID syndrome. We have to face the post-COVID syndrome. It is defined such as patients who come from for presenting symptoms 30 days or more after being discharged by COVID-19 with a negative PCR, but that produce systemic symptoms such as inflammation, coagulation, thromboembolism, the persistence of lymphopenia, asthenia, the hyperglycemia, thyroid disorders, elevated transaminases, nausea, vomiting, diarrhea, urticaria, rash, people that agusia and anosmia, myocarditis, arrhythmias, pneumonia, fibrosis, respiratory distress. We are learning and documenting, and that's why it's very important to document, because knowledge is what can lead us to prevent better. So now we know that there are antibodies that serves against SARS-CoV-2, but that they are not enough. We we need antibody neutralizing. We have to know what NK cells make as well as T cells. We also have to know how to deal with neurological phenomenons. Another things that we have learned is that there are collateral damages. We can see that the deaths by diabetes, how it was the mortality rose. The factors are multiples. Mental health is also has been also very important. There are financing variables. It's not the same the contact that we had that the staff had with restrictions that were imposed with this pandemic. There are psychological affections, academic and social affections as well. We have to deal a lot with mental health. I give an example that is the race and alcohol consume related with a decline on psychological health. And there is a direct and very important relation that we have to study in the future. There are the possibility of new antivirals. Some of these are some strategies inhibit or kill the virus directly or being disruptive of the acid nucleic ensemblage, the interference with virus binding membrane function to prevent the virus from entering the cells, inhibiting the biosynthesis of the virus, inhibiting virus assembly, and of course improve the antiviral capacity of the host. So in my list, in my last, what have we learned of the pandemic? We have learned that the importance of the vaccination. At the institute, we have a process of a reconversion period, and then a de-reconversion, and 12 months in a hybrid system, where luckily we have much more non-COVID patients than COVID patients. What does it needs? It needs reforms to health system in order to have a continuous improvement. It requires a transformation in free coverage in public sector, and it requires universal healthcare services, strengthening the infrastructure, having more innovation that may be in several ways. What is clear is that medicine is not a simple monolithic narrative, but it responds to a series of changes and innovations. We have to size the environment, we have to size the young people, and of creating an engaged minds in order to develop the new science that this pandemic has been meaning. And I finish with Piedra del Sol poem. Oh, life, to live an already lived time that returns in a tidal wave and withdraws without turning the face. What happens was not what is being. And this is the pandemic is still with us and silently flows into another instant that similarly is fading with time. Much more, I would say, we have to learn and reflect of this pandemic. Thank you very much. Thank you very much for your intervention, Dr. Kersnovich. It is interesting to emphasize in this idea to transcend the health section, seeing as a lack of disease, to understand it more holistic way with external factors that are around the human being. It's also important to emphasize the how Mexican state and the process of vaccination and research on the virus behavior is very important, as well as COVID, post-COVID syndrome. It is a constant learning and horizontal as well. So Dr. Kersnovic has told us that he will have to go around 12 o'clock, but in case we have questions for him, we will send them via email. Thank you very much, Dr. Kersnovich. Next, and to clarify the strategies that were implemented for health promotion, prevention, and mitigation of COVID-19 from primary health care, we have the luxury of having the participation of Dr. Hortensia Reyes Morales. Dr. Reyes Morales is a medical surgeon from the Faculty of Medicine of the National Autonomous University of Mexico with a specialty in family medicine. She holds a Master of Medical Sciences and a PhD in Sciences in Public Health with concentration area in health systems. He was head of the Epidemiological Research and Health Services Unit at the National Medical Center Siglo XXI of the Mexican Social Security Institute, director of the Determinant Challenges of Health Systems at the National Institute of Public Health, and Deputy Director General for Quality in Health for the Federal Ministry of Health. She is now currently director of the Health System Research Center of the National Institute of Public Health. She is appointed as a researcher in medical sciences of the National Institutes of Health and is National Level 3 researcher of CONACYT system and member of the National Academy of Medicine. She is author of more than 150 publications in national and international magazines, 54 book chapters, 5 books, professor of the Master and PhD programs in Health Sciences of UNAM and the National Institute of Public Health. She has directed 5 specialty theses, 32 master theses, and 18 PhD theses in medical and health sciences. His main areas of research are precisely primary healthcare, quality of healthcare, evaluation of health services and systems, and innovative models for health services, among others. Please, Dr. Reyes Morales, we will be pleased to listen to you. I will give you the floor. Thank you very much, Maestro Carlos Iván Garcia. I would like to thank CS, Dr. Daisy Corrales. It's a kind invitation to participate in this webinar that has been interesting to listen the speeches of my colleagues. I am going to talk with you a little bit about this strategy. This strategy of prevention, attention, and mitigation of COVID within the framework of primary healthcare. It was a strategy. I would like to present the context of what this strategy was about for those who doesn't know it. This strategy was designed in July 2020, several months after the pandemic of COVID-19 started. It was designed by Ministry of Health through the Health of Institute for Welfare and the Undersecretariat for Prevention and Promotion of Health through the National Center for Preventive Programs and Disease Control, SENAPRESE, and in collaboration with the representation in Mexico for the Pan American Health Organization and the Welfare Secretary. This strategy had as a main purpose to diminish the cases where the pandemic was in the first months, and it was generating a lot of complication and mortality in a way that it was thought to intervene communitary level. And it would have to be very important to make some health promotion, risk communication, prevention, detection, and opportunity detection. detection to avoid complication and hospitalization up to it was possible in a scenario that it was unknown the evolution of the pandemic. But at that time, everything was unknown. It was a disruption in all the health system. And nevertheless, despite the need of these actions, that it was very important that the strategy would also consider to keep the continuity to essentially healthcare essential actions as part of the normal responsibilities of health minister in such a way that it was thought that only not only to identify cases of COVID-19, it was also necessary to detect early the people who had risk factors and would have to be in the community and could be interrupted its treatment and have any alarm even though they didn't have COVID. But also was important to detect early localities or communities with suspected cases within the community in order to identify communitary uh, breaks in order to control it. As I was saying, to give attention to the normal health system projects. This strategy was to strengthen the local health system to give answer of vulnerable population to COVID-19 with these communitary actions and to first contact with a primary healthcare focus, prioritizing risk groups. How this strategy was implemented. The design of the strategy implied three main branches. The first one was through a communitary team that it was taught in savvy staff, the welfare program, health staff, health promoters, general nurses that could be in the community detecting possible cases or people with high risk. The second brigade, that was called Specialist Brigade. The first brigade was called Communitary Brigade. The second one was so the first brigade, when they detected something, they refer to the second brigade, which was formed by a nurse and a specialist. And then the third part of the strategy consisted not in a brigade, but a clinic attention team that has to be implemented in medical units, basically the health centers, where they could receive sick people or people that could have any chronic diseases. Or, for example, the main programs such as vaccination for key children, attention for pregnant women, or cases that wouldn't need hospitalization. This was a general way in it which it was designed, the strategy. But simultaneously, with the emergency sanitary situations, the states started to work and developed initiative to give response to this pandemic and that were effective so they could face and in coordination with the federal proposal to attend the population. This is the general context. So a group of researchers, we were asked, and have the honor to coordinate the the PAHO and Senaprese asked us to make an analysis of the implementation analysis of the APS strategy, as well as the progress of coverage and result in short term in five states: Yucatan, Sonora, Coahuila, Tabasco, and Guerrero. How these states were advancing, because they were the first one in which the APS strategy was considered to start. The time in which we worked was, we started to analyze the results in October 2020 with a first stage that was a situational diagnosis to see two things. The first one, how were they making their analysis of the advancement of the strategy through its own information systems, and how they keep with health priority systems. This was a very objective information, but also it was very important to know the perspective of health staff. In which way? In this way, we make in this between October and December 2020 interviews with key actors, directors at the level of state, and selected health units and teams that were in contact with patients, and as well with the health teams that were going to the communities. In 2020, we could see the advancements of the strategy. Then we make a second stage that was between March and May 2021 to see how they were advancing in the coverage and of the processes and report of results of the APS COVID strategy, as well as what other actions to strengthen the APC model through the analysis of primary information in the field and interviews with key actors. What do we found between October 2020 and May 2021? The main one was the identification of differentiated responses to health emergency in each state according to their available infrastructure and human resources. And that was a limitation, or it was more independently of the strategy proposal. We also found out that the use of national information system for measuring the results and systematizing the actions of cares, control and mitigation of the pandemic was confirmed. We didn't find out that there was a source of information that were local, its own unit registers, so they could lead the actions in a context of a local information. They took as reference the reports that were sending to concentrate at a national level, and that PASA date they were used throughout the pandemic. A lot it was it has to be with the impossibility of organizing a database. An exception was Tabasco, which has a very important database and way of organizing the information. What other things we had? We find out some very important innovative actions that are very worthy to know, because they can be an example because they were successful, and some were related to the strategy, the APS strategy, but Oh, but you will realize that the strategy was overwhelmed. The states didn't follow the strategy as it was stated in the document, how the strategy could have to be implemented. Why? Because it was impossible that they follow it literally, because there was not an evaluation whether they had the enough resources. So it was like a mixture of actions of the APS strategy. Or, for example, they did make brigades, but it was epidemiological and healthcare brigades, not a communitary brigade. Secretary of Navy and Insabi were supported. They also made home visit as the strategy stated, but a very personalized one. And they also have communitary healthcare. Some other states implemented healthcare by telephones and applications. This staff that was going to quarantine, they keep teleworking via telephone consultation. So it was this disposition was to be highlighted in order to help to the response to the response for the community. We have also to highlight that there were online training for health personnel on COVID-19 prevention and care issues, and it was around June 2021, and it was to the response of the health personnel, because the health personnel didn't know how to attend COVID-19 patients. This was an innovative action from the states. There was a lot of information, uh, such as for example, in Spanish and on the other indigenous languages. For example, in Yucatan, there were messages and information in Mayan language. Telephonic centers of information were installed. There was also a dissemination of prevention messages, telephone counseling centers, and entry filters to federative entities and municipalities. There were, for example, in Sonora, a special COVID program that was called Anticipa program. In Tabasco, there was another program called Enjambre Ciudadano. It's like a call center, but to help patients. They had it before for other issues such as gender violence, but they widened it to COVID-19 attention or Yucatan health program. There was also adaptation of health centers and hospitals. There were filters on health center entries, signposting of care routes. In bigger cities, there was a possibility to destine exclusive areas for COVID-19 patients. It was also adapted health centers of Centinela program, or as well the adaptation of urban health center to respiratory diseases called USMER, and the implementation of hospital conversion. These pandemic experiences allow to identify how is it possible to strengthen the coordination with other dependencies and social actors in an emergency situation, when previous the pandemic, the coordination, interinstitutional and intersectorial coordination has been really complicated. Nevertheless, within the pandemic, this was possible with social security institution for care without membership restrictions, but there was also coordination with municipalities for home doctor programs, transfer of patients, and promotion action. It was very interesting to see in rural areas how municipal presidents and population and the community help with the vehicles. There was a coordination with local media and with authorities of native people, healers, and midwives. This was innovative coordination actions of the states that were not in the strategy. But I insist that it's a great learning. And as well as with civil society organizations such as Red Cross, Doctors Without Borders. What happened with the follow up to priority programs? They it was a lot. There was a lot of disruption, even though they tried to follow this home care. For example, for pregnant women and chronic disease, they were also providing medicines for up to 3 months to patients with chronic disease, so they didn't have to go to the units. They gave continuity of public health programs, and they follow up with and tracking patients by phone call of messages. New actors for the strategy. There were indeed new actors, but newly recruited health personnel were rich in, in epidemiology areas, nursing, doctors, but there was a very interesting response of community volunteers. Private sector also help with donation of inputs, as well as public and private university offer spaces for training actions. In conclusion, what are the challenges for the implementation of the strategy? One of the great challenges is that the lack of a model of primary health care, that was the main strategy, the main objective, that responds to the need for comprehensive, continuous, and coordinated care to respond to health needs, because this model implies to give integral attention for the people, not only for a specific disease, but to promote a coordinated and interdisciplinary work, which was impossible during the pandemic. And it's still a challenge, the confirmation or the organization of this model. But it has been always like that. The need of the integral implementations with interdisciplinary teams that really go to the patients throughout the life of the patient, of the population. The second challenge is the need to reorganization at the level of health jurisdictions and care units, a very coordinated response. If we want to have to strengthen health system with a good quality of attention, these coordination actions, especially of the level of jurisdiction, thinking that the organizational level can be done, but still there is a lot to do. The attention to rural areas. So the greatest impact on rural areas was still being not that as we would like. Another aspect was the difficulty of obtaining inputs with sufficient time to ameliorate the action plans and to respond to the emergency. In conclusion, we can indeed say that the state at least the five states that we studied, have worked hard with from the beginning of the pandemic, and they keep working with their own capacities. Therefore, we cannot leave alone the states, and it's very important to 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 improve communication through the health system services, so the actions can be synchronic and enhance them. Another conclusion is that the local actions that we have to recognize, they were implemented to respond spontaneously and innovative. Uh, to respond to the health emergency with the coordination of health teams. Uh, it is also important to recognize that the continuous training of health care staff must be strengthened, especially now that we have new technological tools that allows uh, uh, online training or uh, patient attention. We shouldn't forget the cultural diversity of the population. We have intersectional and intercultural attention. It must be developed in our health system. A very fundamental aspect, and I finish with that, is the lack of a unified record or information in the analyzed stated, as most of the data provided there is from the various sources. It is also recommended to strengthen the monitoring system and promote periodic evaluation to identify the need to reorient strategies and programs according to the conditions of the local context. Thank you very much. I give you here my email, and thank you very much. Thank you very much, Doctora Hortensia Reyes Morales. It's very important, the APS strategy to detect the people that were risk of having complication by COVID-19. It's such a big and complex national territory. Information systems of this stated that strengthen the managing of this emergency situation. This innovative situation, we have to highlight how the virtual technology served to train the medical staff. So we are going to leave at the last of the panel of the webinar some questions and answers, so we can follow the next panelist. Next, and to examine an aspect as important as that of effective communication, we have the intervention of Dr. Rafael Donatiu Ramirez Beltran. He holds a degree in public administration by the Anáhuac University. He's a master in environmental sciences from the National Polytechnic Institute, graduate PhD in sociology from the Autonomous Metropolitan University, and educational psychologist from the National Superior School of Mexico. He's currently a member of the National System Researcher Level 1. He's coordinator of the master's degree in environmental education at the National Pedagogical University and professor researcher of the Faculty of Communication of the Research Center for Applied Communication of the Anáhuac University. He was director of environmental education of the Secretariat of the Environment, Natural Resources and Fisheries, university and postgraduate professor, counselor of the University of Guadalajara, and he belongs to the National Association of Environmental Educators. He has published books on several topics such as education, sustainable development, environmental education, categories and communicative and didactic potentialities. The case of the PhD in communication research of Tenerife University communication of health for health and pandemic models and analogies in the COVID-19 from two perspectives in Mexico in the Syntaxis magazine, and continuing education and communication in terms of COVID-19 and the poverty situation of youth in Mexico in the FinPes magazine. Thank you very much for your participation. I give you the floor. Thank you very much. I would like to thank Dr. Daisy Corrales, you, Maestro Carlos Ivan Garcia, for the invitation, and thank my colleagues. I am honored to be here. I've learned a lot this morning from the presentations of my colleagues. And of course, what Dr. Hortensia Reyes has shared with us of the strategy. What I'm going to share with you is let's say a chronic of the first 100 days of what this communication for health and pandemic models and analogies in the COVID-19 from two perspectives in Mexico. It's a chronic, really. This is the issue. I was very interested in working topics that were emerging. The first one that I've been working throughout my life is the environmental education issues, particularly the climate change issue. I was following up hurricanes, knowing that this civilizatory crisis was coming toward us. You can read the news, even to a micro climate issue is being affected. I was completely sure that radical changes that was coming to the planet was blown by this pandemic. What I was trying to explain myself what was going on in the Latin American region. And what I was trying to do was a research on environmental communication, but basically whether this was related with the pandemic and environmental general crisis. And what I was confronted, there was two main messages from practically March of 2020. There was start to communicate every day in the evening. But afterwards, I start reading the newspapers, and there was another version of the facts. I was not. I didn't went to the hospitals to gather information. I was only based on what the social communication mass media was telling, and confronting with the official news. So it was like a selfie. So this is like a selfie. So the pandemic, the objective of the research is to analyze communication in the pandemic in a context of environmental crisis. There are several authors that were stating that how our of what we eat is being one of the most important factors of the effects that has provoked, and is of course environmental damage. We make some metaphors as an analogy and qualitative category, we heard a lot the issue of fear, of reclusion, uncertainty, the analogy between pandemic and war, and the new normality. This was diluted. Angela Merkel started these metaphors at the beginning of the pandemic, but it has been diluted because it was a hope, an illusion, that we were thinking of a very radical social change. So I believe that working with metaphors uh, enable us to categorize in a different way of what was saying regarding the pandemic. So we make a review of research close to the object of study. They are all interdisciplinary works that regard communication, health and environment, sustainability, social changes, and pandemics. Because I've been working a lot with qualitative communication, it was very important to state or to highlight of what the people was saying and what Dr. David defined to see whether this narrative was monolithical or not. Of course, it's not, because there are a lot of ways to understand the all the model, and especially as Oliver stated, to break in the disciplinary logic. It was practically impossible to analyze pandemic. It was impossible to analyze pandemic from one single specialty. It is necessary to try to dialogue among sciences and these transdisciplinary visions. So we try to build a theoretical framework where we deal with concepts on health communication, public health. We had to see a brief evolution of the pandemics, um, the epidemiologic transition, the problems on the health systems in Mexico, and how this is being associated with environmental crisis, with the symptoms and the pandemic. And what was said in March 2019 when Lopez Obrador compared with the health system and educative systems in Mexico. I deal with the educational system in Mexico. So so we knew that the health system in Mexico was really bad. And that's why the database of the pandemic was atrocious, was really difficult to deal with, as well as other epidemics such as the comorbidities, diabetes, for example, hypertension, cancer, and poverty, that of course we consider as well as a pandemic. So why we use metaphor? We use metaphors as scientific categories since they allows us to pierce the most superficial stratas of the discourse to access what is not said in it, its cultural or ideological presuppositions, its persuasive strategies, its contradictions or inconsistencies, the interests that are at stake, solidarity, and latent conflicts. It's a method based on analogy as a socio-metaphorical analyzer. As well, this three model of generation communication for health. So it was the turn of the screw. It was to propose these three generations, and to propose this way of communicate health, vertical and prescriptive way in all the levels of attentions. And the second one, that is more with campaign base, and the third one that we are aimed at specific audience. This third generation is much more horizontal dialogue, interactionist dialogue. So what we ask, which of these three models was betting in Mexico? We are talking from March 2020 to June 2022. And through all this time, it has been modifying significantly. So we have to cross all this universe of the categories and these three model of communications. Why do we talk about these categories? Why do we talk about fear? And it's very evident. Fear is latent in our society. Fear is a variable that is still there. The issue of seclusion, the confinement of humanities haven't we haven't faced seclusion, an uncertainty issue. But I believe that that the people who specialize in the health issue, we have deal with uncertainty, and as well the metaphor of the pandemic as war. Even now, the fifth wave contagious, we saw that sometimes it feels as if we were talking of a war, or as if we were dealing with a war, even though this last wave is not as mortal as the previous waves. As well, if if our wall, if we want to this recovery to be sustainable, if our wall must be transformed to be resilient, we must do everything we can to promote a green recovery. These were words from Angela Merkel, and the idea is very important because we have to take to seize this historical moment and to change all the paradigms through the sustainable objectives of the 2030 agenda. The first Mexican government bet in the first 100 years. So, so this is what we saw in the first 100 days, and how the government communicated the information daily in the evenings. This was a possibility of talking of specific issues. Uh, uh, the how was, for example, the availability of hospital spaces, and we presented this chart where we compare the communication, the model of communication of second generation, and, for example, from the federal government, López Obrador was stating, we have to beat confinement and fear as a matter of personal responsibility. We have to overcome not only the pandemic, but also our fears, of course, with care. The first thing is health and care. So the communication among the people, an informant would say, if it were to spread further, I don't feel that we are ready for what is coming. That is fear. Since there is a lack of supplies in hospitals, there is no education. I don't feel like we are ready. And so here I present the second generation communication model that Lopez Gatell is saying, and comparing with what the people is saying, the amount of negative information that we receive. raise our anxiety, the daily counting of victims around the world, the state alters permanently, and all the information that arrives from social media affects you and makes you think that that you can be sick. So we see here uncertainty. The first generation communication model is another possibility, and we see that from the government dominates, despite everything, this important political social change. The first generation communication model is dominated. The the uncertainty regarding the lack of care in health, so it's very difficult. There has been like very radical changes, especially in workplace. The use of WhatsApp and teleworking, there was very important changes. The, the issue of comparing the pandemic as war, if you see, for example, this declaration of that is related with emotional support, you will realize that indeed there was an affectation beyond health, and how the people was perceiving it, and how the media was communicating. So all the references and all the narratives are documented in this work. The new normality as well. Um, so López Obrador was stating that I took the decision of going on tour because we need to restart our public life. We are going well. This was stated by López Obrador, and the federal government had a strategy that was very interesting to see how this was being developed from the government and from the media. So the analysis of the discussion of these results is that indeed Mexican government did what they could do in the moment of circumstances that was beyond our possibilities of understanding. And when we saw in terms of what is going on is a health system that we have to rethink. For example, I would ask, and during decades, it was an individualized health system was applied, but now that model cannot be still being done. So conclusions, interdisciplinarity is a possibility of scientific and complex approach to the problems of reality. Communication for health, the environment, official policy, economic history, and work in the media cannot be treated as watertight. It is necessary to recover scientific knowledge and integrate them to understand phenomena such as the pandemic. We learned that we have not been able to relate sustainability with nature, and one of the effects of what is considered an environmental crisis is precisely the pandemic of 2020. The pandemic is not only a symptom, as is climate change, biodiversity loss, or social inequality, but this crisis, health, economic, educational, and environmental reach, must be changed. So we thank to the Dr. Ramirez Beltran for his position, and it's clearly with environmental issues, crises are not are related with health issues, and with these metaphors of health seclusions. So once expose the capacities of health systems and the multidisciplinary teams that were created. And from this communication perspective, we would like to would like to close this part of the webinar, so we can start the question and session session. So the first question: which were the challenges that the Mexican health system faced for the pandemic when the pandemic was in transition between the extinction of the popular insurance and the INSABI and the born of the INSABI. So we open the microphones. So please, Dr. Hortensia Morales, thank you very much, Carlos. I believe that this question is very relevant because it was a really bad luck that when these changes were being done, the pandemic was started. So the health system was not prepared, especially because the financial protection was eliminated from the Seguro Popular. INSABI did not substitute Seguro Popular only in the protection financing because INSABI pretending to be a health holistic system, and the Seguro Popular was not that. So it did affect it because financing for this program at that moment was in limbo. And I believe it's still in limbo. But at that time, it was the thing that affected. In service issues, I believe that it was going to be very similar because the services of the Seguro Popular were given by the first care systems of the Ministry of Health. So, of course, they would have the same problems having or not Seguro Popular. Because what really happened at that time is that the healthcare systems were given by the local medical units. Population felt unprotected because they didn't have Seguro Popular, because a lot of people didn't knew exactly what does that mean. So I believe that they didn't went because they were afraid that they were charged and they didn't have money. Thank you very much, Doctora Hortensia. Dr. David, please. I agree with Dr. Reyes that it created a lot of uncertainty among the people and indeed a lot of doubts. Nevertheless, I do believe that it is important to highlight that in public sector, at the level of the health institutes, at least there was the people did not spend money. All the attention that was given for COVID-19 was covered 100% by the health system. So we have to make this little difference. I already don't know what had happened at the level of the states, but in the health institutes, COVID attention were free for all the patients. And it was clear from the beginning. And we have to emphasize that. Thank you very much, Dr. Kersonovich. So I read another question. In what way hospital reconversion affected in the in health of the population? And I am going to mention another question, which has been the organizational strategies to diminish the impact of hospital reconversion in the health of the patients. I'm going to I'm going to answer. Evidently, the collateral damage toward other diseases have been very important. The pandemic was accompanied by a great uncertainty, a lot of fear, as it was mentioned in the opponents, in the in which the staff, the medical staff, didn't know how to react. Uh, One of the social phenomena that I was more impacted by it was that it was hit all the health system. There was a lot of uncertainty. We have to remember, of course, people that had diseases were affected importantly, and that also created a lot of uncertainty among the people that needed, for example, surgeries, special surgery that couldn't find a place where he or she could be operated. And this was a worldwide phenomenon because hospital saturation was very, very normal, but was very common, not only in Mexico, but in a lot of countries. So I believe that to check all this data, we have to be very flexible on understanding factors that led to hospital conversion and to the hospital reconversion. I put a single example. If in Mexico as we had only one place to buy food, what could have happened with the alimentation of the city? So it requires a very complex analysis of all the decision making that were done. Thank you very much, Dr. Kersanovich. Definitely, we wouldn't have enough time to mention all the positive and comments for you. I'm going to mention only one before you leave us. As it demonstrated with few words, the medical commitment, such as Dr. Kersnovich, its knowledge and its direction of the nutrition center make the difference in health system. Because why can't we have more doctors as yourself? Thank you very much, Dr. Kersenovich. With few words, you have explained a lot, and you say it clearly for those who are not doctors. A lot of success for the stage that you are living right now. Thank you very much for your participation in this webinar. Dr. Mesa, go ahead. Thank you very much for the opportunity. It's a very important question. I agree that there are specific criteria that oriented the government to take this reconversion decision, and probably these decisions were taken taking into consideration all the alternatives due to the financing context in Mexico and due to the complexity of organizing or reorganizing a Mexican health system in the conditions that it was. Nevertheless, making an autocritic, I believe that if we had a similar scenario, we have more knowledge on the collateral effects that we faced, and we can take them as learning. One of them, for example, is that indeed there are things that hospital organisms cannot solve. For example, communication towards population, and the population start to gather information from different mediums that are not very reliable, or that they have any political intentions. And nevertheless, those uncertainty, those kind of information uncertainty generated that a lot of people at the time that there were hospital 100% COVID. So the people was strategy. Instead of going to COVID hospitals, because you had the idea that if you went to a COVID-19 hospital, you were not going out. What? So people went to other hospitals. Sometimes those hospitals were prepared, sometimes they didn't. There was an increase of the use of particular medical services precisely to to heal diseases that probably they were COVID, but they were not going to COVID hospitals. So there are a lot of very important issues that we have to take into consideration on phenomenon associated to primary healthcare attention that cannot be controlled exclusively by hospitals. There are hospitals in Mexico City that are high quality. They have all the instruments, the equipment, but there are a lot of heterogeneity in hospital services within the country that difficult, for example, or it makes more cost to say no. Because if you say no in some places, perhaps that is the only hospital that you have to attend that diseases. Those things, for example, in Aguascalientes, you couldn't do that. You cannot go to another hospital because there are a lot of hospital alternatives. So I believe it is very important to rethink, or if we are going to think again, a hospital reconversion, it is going to be very important to know the collateral damage to offer a best quality of public health for the population. Thank you very much for your intervention, Dr. Mesa. I'm going to make another last question and we will finish this webinar. What is your opinion of the fake news and political campaigns that were questioning official communication given by health minister? Please, Dr. Rafael. So let's say that the fake pandemic phenomenon is not isolated, is within a bigger social transformation context and technological context as well. I believe that nowadays all the works continued, whether teleworking or in an hybrid way. But in the WhatsApp, for example, nothing was clear. So the issue of fake news was definitely a very important player within this pandemic. Now we have more mechanisms that even the young people goes, for example, how to delete a fake news, So to search a solid reference, for example, but at the beginning of the pandemic, we didn't have anything of this. So we saw some things that were fantastic. Guadalajara University invited us to make how uh, how was the pandemic living among the university context. So we, for example, we copy a WhatsApp of a director of a research center was sending to all the students. Communication became horizontal. Mexican educative system, everything is prescriptive and vertical, but facing pandemic, it became horizontal and not always with the best effects. Indeed, we communicate a lot and we learn among us, but also we open the communication by social media and this message that we can avoid looking for scientific references. Thank you very much, Dr. Rafael. I'm going I'm going to ask another question specifically for Dr. Reyes Morales, and the question is, why was it considered, or what was the parameter considered analyzing the cases of the stated in the APS strategy? Thank you very much, Carlos, and thank you for the question. It's very important because, in fact, the states follow the APS strategy a little bit. There were some strategic criteria. For example, vulnerability was a very important criteria, or suspected cases. Those were the basic criteria as well as general criteria. For example, for children or pregnant women or chronic disease people. Nevertheless, the state did attend this part of the population with self initiatives more than following the strategy. Thank you very much, Dr. Hortensia Morales. So we are going to close the webinar. We have here Dr. Daisy Corrale Diaz, Director of the Inter-American Center of Social Security Studies. So we will ask her to close the seminar. Thank you very much, Carlos Ivan. Thank you very much. I am pleased, and a special greetings to Dr. Hortensia, Dr. Mesa, Dr. Ramirez, Dr. Kersanovich. Thank you very much for sharing with us this such a very important experience that whether all the countries face the very difficult situations and an uncertainty state in which it was evident which were the capacity that we had. In Mexican case, for example, there are such important experiences, such as the ones that you have shared with us, especially because of the size of this country. We are talking about the 130 million of people, where the cultural diversity and diversity in generally in these 32 states puts us in front of a very big challenge. If we compare it with some other countries of the Americas, each of these states are almost a country. So to be a condition where it is combined all that it is, the normatives and the strategies, the federal and the state strategies, you have a very level of response. And after listening, I experienced the pandemic in Mexico, and I could see a great organization. You mentioned very important factors, such example, managerial issues, organizational issues, institutions working together, sectors working together. That is not easy to achieve in such a complex country. So in the midst in all this thing and part the scientific part, the scientific studies that you share with us from the standpoint of your scientific knowledge from technologies, all this process of reconversion that at the end was like um, a the power, for example, to have this experience to oriented or what can we do when this such an event as a pandemic is what can we do the 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 power to analyze from the healthcare system, the state organization. It's clear for us that one of the best way of facing these problems is a political willingness to face the problem, where it allowed to broke the institutions, the health systems, towards a public health system. And of course, we are facing a future healthcare system. When we talk on a social security system, on universal coverage, they are paradigms that were on evidence that how humankind needs an attention where social security are very, very important. Uh, the people that went to the hospital services and with all the preventive measures, they receive all the inputs, coverage, medicines, and possibly you have to still analyze what was a response or how was the financing issues, because in especially in first health care, to dimension the needs of a country is very complex. And I do believe that today it was for us an honor to have all uh, of the, of you as a Mexican expert in different fields. We can give a general image of what was the attention and how we are facing towards a post-pandemic era with a series of factors that we haven't still been able to analyze, but they are living evidence that even though the pandemic went, there are still syndromes or they can have uh, consequences and diseases. What happened with the people who had a chronic disease and had COVID? What happened with those secondary effects that were highlighted in post-COVID symptoms? We don't know still. There was another sad factor that was the loss of the the the, the staff, the personnel that died among the pandemic. We have to face this problem of the lack of staff as well as an economical and financial crisis. And other factors, social factors such as migration, wars, environmental crisis, all of that affects us. And we are living a time of changes. It was also mentioned, for example, from the panelists, the importance of information technologies on how to fight and try to communicate effectively, where really we can know that information and how at the end a great effort of the states is going to depend on the individual willingness and on the people being responsible to have the measures. So I believe this has been a very special morning. I know that all the countries that are here with us thank all the panelists. And we from the Inter-American Conference of Social Security, uh, Maestro Alvaro Velarca, General Secretary, and myself, Director of the Inter-American Center of Social Security Studies, we thank you all, and we keep uh, with these webinars to exchange knowledge and experiences that are a benefit for the population. Thank you very much.